Ekin. Perfect. Hello, everyone. So this is Tahir Ekin, and here we are basically in this panel that will focus on data, basically AI, focusing on healthcare, and we have three experts. I will serve as a little bit more of the moderator today. So again, our objective is to have a basically discussion about the use of data and AI to come up with developments in healthcare, talk about the basically current climate, some of the opportunities, challenges, as well as basically future, right, to the best of our abilities. So let me introduce myself, and then basically we will start with brief introductions before getting to the discussion. So Tahir Ekin, I'm field chair in business analytics at Texas State University. I'm also the director of Center of Analytics and Data Science at Texas State University. And Barbara?
Okay, hi, I'm Barbara Hewitt. I am an associate professor at Texas State University in the Department of Health Informatics and Information Management. And I'm excited to be here. Thank you. Go ahead. Type.
Perfect, Barbara. Scott, maybe we can continue with you.
Sure. This is Scott Burk. I'm a founder of It's All Analytics, a company that I founded, and I teach at CUNY in their Master's of Science in Data Science program, and author of a few books.
Perfect, Scott. I think we'll learn more about those books and potential relevance to healthcare. Tevfik, please.
Thank you, Tahir. My name is Tevfik Aktekin. I'm a professor in the Department of Decision Sciences at the University of New Hampshire. I'm not at New Hampshire right now. I'm actually in Austin. I'm visiting Tahir and a few co-authors. I'm on a sabbatical run right now, enjoying every second of it. Thank you for the invitation. Looking forward to the discussion.
Perfect. Thank you all for being here today. And yeah, maybe we can start with talking about data, right? And obviously now, especially the recent emphasis has been more on AI, but almost all of us have been in this basically data analytics, data science, AI, basically data-enabled method space for healthcare for a while. And maybe we can start with Scott. So Scott, can you elaborate on the importance of data in healthcare?
Absolutely. So, and I'm going to start with data in general. You mentioned AI. Obviously, you can't do anything in AI without data. And even more importantly, you can't do anything in AI without the right data, right? So, you know, at the very simple level, anything that records an event or a process is data, and that data could be in your head, it could be in a database, it could be a spreadsheet, it could be in a Word document, whatever. But essentially, all recorded thought process is data. And again, it may not even be written down or may not be recorded digitally. But and then I firmly believe that data is the foundation of all improvement. You can't have any sort of improvement, be it medical, clinical, operational, without data. So it's a requirement for that. It's a requirement to prove the scientific method. If you want to do an FDA clinical trial, you have to have data to be able to do that. And so it's the foundation of everything that we're talking about today. It's the foundation of all analytics. And we tend to, focus on the sexy stuff. But, even in healthcare operationally, everything that we're doing, even from one of the big improvements in healthcare right now is even task lists, so that you can be able to record and improve operations through that. So, and then, we progress through different things. I remember back to the right data for the right task, I can remember as a statistician being involved with FDA trials. I'm getting a bit of something in the background. I'm not sure, maybe it's just me. Anyway, so everything from, the medical record information, these trials, the protocols, researchers and everything were collecting mainly on-premise clinical data to do efficacy of drug trials. Statistical methods mainly back in the day. And then as we progressed, in 2003, we mapped the full genome, right? The Human Genome Project mapped, and we thought we were done, right? We knew everything that it was because we knew the human genome, what it should be, and then we could look at variations between the genome and do scientific studies on that and determine if someone had certain problems, certain cancers, that genetically disposition to whatever. Then we learned that really the body doesn't function just on the genome, right? It's dynamic. It's really the proteome, right? It's all the proteins and everything that are going on in your body. And I think most people are familiar with mRNA now. It came around with COVID. I think it was for most people, it was a new thing with COVID that, it was actually the messenger RNA that was really kind of the key to it. So that little point is that we are constantly catching up with what data we need. As we discover something new, we understand that there's data that we need to capture to fully understand and evolve to the next level of analytics. So that was kind of the point behind that. And then just one other case point is a prediction algorithm that we developed for asthma. And we learned very quickly that if you looked at just the EHR, that electronic health record or EMR, there was so much missing data for asthma. I mean, if you had an asthma attack that sent you to the hospital or to the ER, it was not going to be in the medical record. It was in the atmospheric data. It was the data quality. It was whether you had pets or not. What was your socio-economic status? So there's all this ancillary data that was outside the premise. And in healthcare and medical science, we're learning that there's a lot of important ancillary data that we have to collect and bring in and make sure it's available and cleanly. And so anyway, just a few points on data.
Right. No, all great points, right? I mean, I think almost everything started with like figuring out what is missing. Even if you go to 200 years ago, let's say people were getting disease like cholera, right? And just trying to figure out how it started, and then, the links to the sewage system and whatnot. And then, in the modern day, especially, that was the bread and butter of the stats applications, right? I mean, the clinical trials, and we know a lot at this point. And obviously now with the power of computing, things and methods kind of have changed a little bit. But especially, I think your comments about data quality and importance of missing data, handling that is one of the, I think, overlooked parts, right? As you suggested, everyone goes for the more popular applications, and we may revisit that, but maybe now that we set the stage with data, let's talk a little bit about the methods. And Tevfik, you have been working on especially some statistical modeling applications, right? So in healthcare domain. Can you briefly give us a background of maybe what you have been involved with and what is possible, what excites you in terms of methods?
Just to I want to be brief. You can stop me anytime, Tahir. Sometimes I talk too much. So, but just to give you an overview of what I've been doing for the last 14, 15 years, my research area or things that I'm interested in are dynamic models. By dynamic models, I mean models where you learn from data over time or over spatial units. And a good application area for that is disease mapping. That's not the only area that I work with, but disease mapping is such an area. I mean, using modern example, right? COVID-19 was one of the areas that we've dealt with. In the past, we've dealt with HIV mortality. And the thing that I want to kind of emphasize on, I mean, the terms like AI, machine learning, analytics, you know, depending on when we kind of focus on these terms, they may mean something different. But for me, fundamentally, what I care about are temporal patterns or spatial patterns that you can use to make methods that are more viable in analyzing healthcare data. For instance, when you're dealing with some kind of infectious disease like COVID or HIV or what have you, the correlations across spatial units could be things like states, or they could be a lot smaller, like zip codes or some kind of well-defined spatial area. Knowing, let's say you have an area and then it has some neighboring counties or states, what have you, knowing the numbers, mortality counts in one area will influence your opinion about the others. But not only that, this is evolving over time. So knowing what happened last week, let's say you're dealing with weekly data or daily data, or I've dealt with high frequency interval data, like 10 minutes, 10 seconds type of data, the temporal patterns that you're kind of observing from the past will help you about the future. So being able to kind of capture these types of correlations across time as well as spatial units, I think are key. One of the things that what I'd like to call the black box machine learning and AI approaches, I'm just going to dump my inputs into my process, and then it's going to feed me an output, but I want to be able to interpret everything in between. So kind of using these type of methods and also taking into account correlations across, again, spatial units or temporal correlations will help you better understand the past as well as make predictions about the future. So in a few of our cases, we were able to kind of show differences between, our focus was using socioeconomic factors, things like poverty, income inequality, things like that, their effects on mortality, like HIV mortality or COVID-19 mortality. When you don't take into account these spatial correlations or temporal correlations, the inference that you're getting is vastly different. So it might lead to a decision that will kind of trick healthcare providers or people who are making these healthcare decisions at the higher levels, thinking that, let's say, in a certain region, the effect of poverty or inequality or what have you, maybe is not as prevalent as you thought it was based on standard models. But when you take into account certain correlations, the story could be different. And again, I'm not saying that every time that's what you're going to observe, but being able to account for these type of dependencies have been key in my research, in many other fields as well, but especially in disease mapping. Does that help, Tahir?
Yeah, definitely. I mean, I think one thing I think that you emphasize is we have a set of models available, and obviously it's the focus, it's the objective that matters, right? While picking up the right method. And sometimes we are interested in prediction, sometimes we are interested in more explainability and the relationships basically among the variables. So depending on the objective, we may pick a different basically method from our toolbox. And maybe we can get to Barbara. Also, Barbara has been basically working on models and obviously information systems, frameworks related to healthcare. And maybe, Barbara, you can focus on, so what about the impact at the either patient level or the population health level? So can you provide us a few examples and your thoughts?
Yes, Tahir. Yes, I have been looking at different models. One of the things that I looked at, and I started looking at this probably in around 2015, was Healthy People 2020. What are the trends with the national population? We were studying it at the student level, and we studied it different times. We gathered our data. We're about to redo all of that with Healthy People 2030. And it's nice to see that some of those areas have changed and have been improving. Health equity, like Tevfik mentioned, that's a huge issue as well. And we see that sometimes when we're analyzing data as well. And social determinants of health are another big issue that we see a lot of, and we have to be really careful when we're analyzing this data that we're not making assumptions based on the population that some part of the population isn't a part of. One example is when we were analyzing diabetic data, and we found that a lot of the diabetics were not taking insulin, and everybody wanted to infer that was because of money. And the issue was the data we were analyzing, and this comes back to data quality, didn't ask whether they were a type 1 or type 2 diabetic and whether they were insulin dependent or not insulin dependent. So we couldn't actually make any inferences about equality or about social determinants with that data because it didn't ask the right questions. Then there's, and that was a study with big data using a national database. And so when you're looking at some of the data that's out there, you've got to be very careful. We've also done some studies where we're analyzing images. And, so I went out yesterday and today, and I started thinking about, well, we're analyzing these images because the radiologist can't look at every image at the level of detail that they need to. And so I started doing some reading about the radiologist, and reports say that they can look at 150, and then another report says 700 to 800 studies a day. And, and then it's like, that means very little time is spent on images. And there have even been lawsuits because the radiologist didn't spend enough time looking at these images. So taking AI and using it to analyze these images and throwing out to the radiologist the ones that might have anomalies is going to help this quite a bit. And when we think about it, we don't just have x-rays, we have CT scans, MRIs, bone scans, on all kinds of other scans that are part of this. And I know one time I was brainstorming with someone else, and I said, well, what kind of images could we use? We know breast images for breast care, mammography, and MRIs to try to determine if this person has or will get breast cancer in the future. What about images of the brain? Can we identify tumors, Alzheimer's, strokes, Parkinson's? Are there things in a person's brain that we might be able to predict some of these earlier? And then we can also look at all other kinds of things like skin cancer. My daughter actually did some research on this when she was getting her graduate degree. And it was interesting to see what she was determining: lung cancer, thyroid cancer, colon cancer, prostate cancer, diabetes. Maybe can we predict when somebody might start having problems with their feet? Is there a way to do this? Is AI going to open the door so that instead of that patient going and getting these screenings with the doctor, maybe some AI will be able to do this, and it relieves the doctor from having to remember everything he has to do. Other things that I liked when I was looking at here was even the idea that AI can improve patient engagement. And I started thinking about this because I recently did a study with another faculty member, and we were looking at communications with an elderly population and their physician. And the elderly were saying, the physician's not listening to me. He's listening to my caregiver if they're here. They're not paying attention to me at all. And so, looking at it, maybe we can help that physician. And we have to realize every patient has a different communication style. So we almost, if AI could predict and tell the physician, for this patient, you need to do this, and for this other patient, you need to do this. We don't want to lose that human touch that we have. We don't want AI to do the communication, but if it could help the physician know what works with the patient, wouldn't that be great? Also improve digital patient interfaces. When I go out and look at the system, can it immediately know what kind of person I am as to what it should show me, and improve maybe the self-services and stuff. Other areas that I'm looking forward to seeing more use is interoperability. We have started this. We're to the point now where we're probably 50 to 70% interoperable, meaning when I move from one physician to the next, they have my other health information. But until we have all of that information, even the physician can't do it right because he doesn't often have the entire story. And from that, I keep hoping we'll eventually get a common application so that every time I go to a new physician, they get my information without me having to re-enter it. Drug discovery, I know at least Scott or Tevfik talked about this. You know, it was Scott that talked about drug discovery and how AI is going to help that. You know, there's just going to be so many uses for this tool in healthcare, and we've come such a long way. When I started teaching in '99, my first job was to teach HIM students how the electronic health record was going to revolutionize healthcare. And I can remember the students saying, I don't want to learn about computers. And now we're teaching them how to manipulate that data now that we're gathering that information in health records. Just such an exciting opportunity all around. Thank you, Tahir.
Right. Yeah, I mean, tremendous progress, right? And you have touched upon many important points. And I think that will provide a nice segue to challenges and opportunities. So maybe we can start with, I think, one of the more exciting topics, right? Personalized treatment and democratizing access to healthcare. So, I mean, there is tremendous potential, but why is not happening tomorrow? What is holding us back? Anyone wants to chime in?
Well, I'll just say one thing because it relates to what Barbara was saying about interoperability, and then it certainly leads to this conversation as well. We have made progress in the communication of systems. There is a standard out there now called FHIR, F-H-I-R, Fast Healthcare Interoperability Resource, and it's international. So even across countries and everything, especially for researchers, where one of the big challenges historically is getting one system to talk to another. And that always took a programmer pretty much to get those systems to communicate. But using a standard like FHIR, you can make sure that when you pull a data element, is actually the data element that you want, right? And mobile devices based on FHIR are just exploding, right? So I think that, to your point, that's going to make healthcare much more accessible to so many people, because you'll be able to transport the data in, build the models that are necessary, and then provide services and recommendations for patients. And I'll quit there.
Yeah, no, I mean, overall, and I guess especially, I feel like last 10 years, we all have been waiting for that moment. We have been talking about these things, and obviously blockchain had its moments. You know, there was lots of hype and hope, but still, it's not necessarily, maybe I'm more of an impatient and I'm more ambitious, but it's not happening at the rate that we all want to see. And again, one of the reasons is healthcare is very complex, especially in the States. The system we have is very heterogeneous. It has many players. But like, if you, let's say, basically had superpowers, magic wands, you know, what would you start with? And I think you talked about different aspects. For instance, what is holding from us? I mean, we have the methods to read, let's say, scans, potentially help physicians. Is it the patients are not ready? Is it, let's say, we don't know how to do it from the policy perspective or from the legal perspective, or patients are not ready? So again, in your opinion, what is holding us back for more complete implementation of AI? Is it the technology, or is it the people or society?
I will start. I think it's a little of both. I think that organizations are afraid if something goes wrong and it gets out, hey, y'all used AI to make this decision for me, and it wasn't a real physician, even though we know at this point, AI is telling the physician, and the physician is making the decision based on sometimes what AI is recommending. And in fact, at times when somebody actually goes out and uses AI, they go, oh my gosh, I never even thought of that. That's not what I thought this patient had. But once AI came through, AI told them, this is what this patient probably has. And they were able to get that patient treated much faster, more accurately than they would have if they were doing it on their own. I came into a talk like this one day, and that's what the guy was talking about. I missed the beginning of it, but we're seeing this more and more. But if that patient wasn't treated right and they died and their family was suing, and it got out that AI was making some of those decisions, I think we'd have a little bit of an issue, where the lawyers are going, maybe you shouldn't have used AI and stuff, even though on the other end, that radiology stuff, like I said, there's lawsuits out there because the radiologist is taking fractions of a second to look at hundreds of images, because like an MRI or a CAT scan or one of those has at least 1,000 images, and they only have a minute to look at all of those images. And, so we're challenged on both ends. And on the physician side, I think it's a level of trust. Is this really telling me what I need to know? Is this right? Is this, am I missing, is AI missing something that I'm going to overlook if I trust it too much too? So I will stop and see if someone else wants to add.
Right. And I think it may also be tied to the explainability that Tevfik was kind of talking about. So at the end of the day, and obviously now there has been a bigger emphasis on explainable AI, even like we are making a best attempt to uncover basically what is in the black boxes. But yeah, I mean, users want to know why they got a particular recommendation at the end of the day.
Just quickly add to that, Tahir, like I think the general education in the public domain is important, because a lot of times whenever we use words like, I was just trying to say that, like AI, machine learning, people think about like sci-fi movies where, machines are making decisions and they're going to take over type of scenario. But like for us, like at the heart of AI or machine learning methods are simply statistical models that we've been building since the 1940s, right? Kolmogorov did a lot of the deep learning stuff that we're using, but we didn't have the computational power. So maybe kind of educating the general public about uncertainty quantification, for instance. Going back to Barbara's point about, okay, let's say you want to, if the system, let's make it very simple, pops out ones and zeros. One means treat, zero, no treat, right? Well, for a lot of people who don't have the notion of quantification of uncertainty, they kind of feel like it's like a flipping of a coin, right? You're like, oh, 50% chance here, 50% chance here. But if you know about uncertainty bounds, if one kind of AI terminology or just some method is telling you, okay, treat with a probability of 98% versus treat with a probability of 56%, they are both saying treat, but obviously the uncertainty bounds are higher in one and lower in the other one. And these type of kind of very basic stuff, maybe if the general audience had a better understanding, maybe there will be a bit more trust built rather than just a black box approach.
Yeah, no, that's fair.
Yeah.
Please, Scott.
Yeah, I'd just like to add, because the first time Barbara was talking about it, it, made me think, we have a system where we have human in the loop AI, and then we have human out of the loop in AI. So you mentioned radiology, mammography, and some other things. So there is no doubt that AI can predict breast cancer far better than any human radiologist. It's just no, it doesn't even come close. But I mean, as a patient, a lot of people don't feel comfortable with having a machine make that prediction. And there are circumstances where someone could go through clinical training and they've seen something that the computer has never seen. It's never been trained on. It's never seen before. And so that radiologist will pick up something that the AI will not. And so I think there's great opportunity for both of those, human in the loop AI and human out of the loop AI. Maybe the out of the loop example might be the diabetic patient that needs a foot exam or something based upon certain parameters, some sort of prediction factors or whatever, bring them into the clinic. What a false positive, that wouldn't be a major deal. The second thing, based on the very beginning of this discussion, as far as why we're not moving faster, is I think it's just very, very basic. I think it's incentives. I mean, it's just, you have so many people involved in this chain, right? And everybody has a diverse incentive for advancement. And so they're looking and we know as data people that there are differences between local optimums and global optimums, right? So everybody's looking for their local optimum, and that is not a global optimum. So
Yeah, no, that's a fair perspective. Again, complexity and sometimes lack of transparency doesn't help us. So even, in things relatively on paper simple as pricing, we still, struggle, right? Despite all the data being available. So I guess some of that would take some time. So maybe I think we are at the 35-minute mark. Before asking to audience, let me ask you about what is next in terms of data, methods, AI for healthcare for you, and also what excites you, let's say in the next 5-10 years. It can be something you are involved with, or it can be something you are excited about following through your networks. So any thoughts?
I could start.
Please.
Because I think it touches on I think it touches on many of the things that have been brought up, and that's causality, right? So especially for the difference between a predictive model, a predictive model and a prescriptive model, right? So what happens often is we have predictive models that are very good, but are not necessarily prescriptive, and so that we define terms, because I'm a big believer in defining terms. When I say prescriptive model, I'm talking about a probability that a patient is going to have, say, diabetes, or go to the hospital or whatever based upon their factors. And then a prescriptive model would be, what does that care provider prescribe? What clinical therapy does that person prescribe? And one of the things that I've written about as an example is the diabetic patient, right? With 5 variables, I can predict incidence of diabetes with a very high probability, whether you're going to have diabetes or not. And one of those, back to spatial, is if I know where that person is on a map, I can really tell you the likelihood of that. That's one of the most important predictors of diabetes. So prediction, great. I can do that. Now, there are people that think that they can just use a predictive model and then create a prescription from it, right? What you should do, right? Now, and of course, I use this example as an illustration of the difference, right? What not to do. But you can imagine it's very easy to make, and I've done it in the past where I thought, well, instead of, something that it boils down to a confounding variable underneath, right? So if I try to say someone in Colorado, very low diabetes incidence, right? If I take somebody from Mississippi with a very high incidence, say, you know what, you need to move to Colorado because people in Colorado really don't have diabetes very much. So you just need to move. That's a prescriptive model. Take this action and you'll be better off. Causality is kind of, to me, the next frontier where we look at algorithms that determine whether something is correlative in nature or causative in nature. And for medicine, it's great to have predictions, but if you're really going to the next level, you need to be able to prescribe the optimal therapy for this patient set on this unique set of patient individual factors, right? So that's what I'm excited about.
Perfect. Barbara, Tevfik.
I'm still thinking about that one and not coming up with a good one. So.
Yeah, no, I mean, for me, it's more kind of a personal thing. It's not related to what, how technology is progressing, but I'm interested in comorbidity type of models, namely, combining HIV with something else and then trying to see if learning through that dependence helps us better kind of make predictions about mortality rates. That's an area that I've been talking about with my co-authors for a while, and being able to kind of do it in a more mathematical manner, and then trying to see the effects of, again, socioeconomic factors on these comorbidity, multiple morbidity numbers could be interesting in the future. Yeah.
Complex relationships overall, right? So a lot to uncover. And Barbara, let me ask you a more direct question. I guess given that we are being recorded and especially our students may watch this recording later, obviously you have been in this healthcare data space for a while, and then do you have any recommendations for our students who want to potentially make a career or who want to get a head start in this domain?
Yeah, sorry, I'm in a rainstorm right now. I think they have to have that passion just to take the data, get familiar with it so that they understand when they get results, what those results are really telling them and what they're not telling them. And just start, getting in there and seeing what you think is happening, and then finding colleagues that can work with you to say, no, that isn't, no, you're making an inference that's not there, or wow, that's pretty interesting. And I always revert back to data quality. One of the biggest issues that we're going to have for still quite a while is going to be, is the data we're analyzing good? Was it put in well? Was there user error when it was put in, or something else that happened that will give us the wrong information? And we even talked about this with our students back in the 90s. When we were teaching them stats on healthcare data, we would say, you've got to ask why this number is this way if it's not correct. And it can be so many reasons. In fact, the length of stay at one hospital went up astronomically at one point. And if they didn't know why, and we talked to the students, if you just go and say, oh, our number today is 90, and don't go try to figure out why, then, our length of stay of 90 is not something that normally happens. But there was a benefactor that was dying, And instead of putting her in a rest home, they put her in the hospital. Her family put her in the hospital. So when she did pass away, she just really, changed that statistic. So like I said, part of it is asking those questions. This looks wrong, why? Or this doesn't look wrong, but what does it mean? And I'm a behaviorist at heart. I like to see how people will behave. And a lot of my studies, and a student and I did this for a thesis, and we were looking at people that were taking genetic testing, and we were questioning, will people change their behavior based on what their genetics have told them? And so I think we're going to have this challenge, especially now as we move forward in this age of data, and having the predictions be a little bit more relevant and maybe even a little bit better than they were in the past. And will people change their behavior based on what the computer is telling them? Still, are they going to just go, they don't know? So it's good. There's still a lot of challenges out there.
No, I mean, fascinating topics, right? I mean, still, as you mentioned, domain expertise is and will be so important. And I think that also relates back to what Scott was suggesting earlier this afternoon about human in the loop AI, because we will want to get that feedback and have that feedback loop to make sense of the outputs and potentially improve them. And then the other thing is, yeah, I mean, again, that relationship between the potentially output that we are getting and if we are going to change anything based on that, or if you still want, let's say, medical doctor with the so many years of experience, whatever your trust threshold is, to say the same thing, right? So that's an interesting, I think, phenomenon. So we are almost at 45-minute mark. I know that we don't have much of a live audience, but I want to give them the chance to ask any questions they may have. Albino, Nick, Caroline, any questions or anything that you want us to discuss? I believe you can write it in the chat box if you have any questions. But while we are waiting potential questions, let me try to summarize some of the main takeaways, right? So I think one of the things that we have all discussed is the both potential and challenges, basically with using data and methods in the healthcare space. Although we have had tremendous progress in the last, even Tevfik was dating it back to 1940s, rightfully so, but especially in the last 20 to 25 years with the more widespread incorporation of information systems frameworks, we had lots of improvement, right, with the electronic health records data and basically that digitization. But I think there are still there is lots of potential, but there are still some challenges that persist. One is figuring out the role, the relationship between the human and these digital tools as well as the methods. Let it be human in the AI loop or basically trust issues, how to navigate those spaces. I think still it's an open-ended question. And that may determine the pace of basically progress towards basically personalized treatments, basically, or basically more global health campaigns, communication. And it looks like we have 2 questions in the Q&A. But overall, I think, and then we haven't talked much about the operational side, obviously, especially with respect to decision-driven models, optimization. we have had some basic frameworks being employed as well, right? So two questions. One is from Albino Regalado. How do you see AI impacting the nursing community? So obviously, this has been one of the top discussions, right? That we have the nursing shortages. Obviously, we are aging as a population. We may need more of them, although we have less of them. So any ideas about the impacts of AI on nursing?
Well, I could maybe add just a couple of quick things. One would be something that we talked about a little bit earlier. Barbara was talking about the ability to know kind of the background of a patient and how to best communicate to a patient and basically identify a profile or some sort of, type of communication that you want to have with a patient. In other words, look at a set of factors and predictive model of kind of a profile, right? So that's one thing. That's on the kind of the quality side. I think it's going to be very useful and very helpful on, well, here's an example that I worked on. So one of the biggest things that goes on in hospitals is false alarms on the floor, right? So it's dictated now that nurses have to go around, and for any alarm, they have to go in and it just, short staff, they're just overwhelmed by alarm. So AI could definitely help on determining the likelihood that that's a real alarm or a false alarm. So you could almost triage the alarms that are going off and automate that type of thing. So, I mean, I think it's both very useful on the quality side, improving patient care, and then it's also helps operationally with reducing the load on nurses.
Yeah, no, great points, right? Again, given that we have less nursing hours, we want to make the most of their hours. So I think it could be a good complement overall. And I guess one of the things also with nursing at large is home health aides. So I think now with better personalization, we may have a better idea about the needs and the intervals that we need to use those resources for optimum treatment. So that could be another aspect. Anything else to add? Perfect. Albino, please go ahead if you have any follow-up questions. And Carolyn has a question. She's asking, who is the optimal mediator overseeing body of data in healthcare space? Is it hospital systems or government, etc.? Again, this is a little bit loaded question. I know that.
Yeah, I would say none of the above, but all of the above.
Right.
Yeah, I'd say a bit, all of the above, a little, at least a little bit, right? Joint Commission on Healthcare, JCAHO would be one.
Yes. Yeah, no, we have a lot of good commissions and they're doing a lot of good work out there. And it's a huge challenge from every angle that you look at it. I mean, I think that the data, in this healthcare space is going to be a challenge for a while. And we've also got the fear of the privacy and the security of those records and everything to add to all of this. So who is overseeing, who's mediating, who's making sure the right person has access and nobody else has access is going to be a huge challenge. And I think that's what's going to slow down some of this interoperability and some of the other things that are going on in this space. But, I think it's going to take still a lot more folks to do this. The healthcare systems, I think for a while they were afraid if we share our data with other hospitals are going to infringe on our patients. And, it's like, no, we just, in case they show up, we want to know what's wrong with them, and sometimes they can't tell us because they're, passed out or whatever, or fainted or something, but so both government, the hospital systems, and maybe we put the patients themselves, and that the patients need to start advocating for this governance of the data and the sharing of this data throughout the space, so that when I present myself anywhere, we have they have my knowledge, or they have the knowledge they need to treat me right, the way I need to be treated or something.
Right. I guess that was even a big like discussion point and concern, and maybe missed opportunity, especially in the early days of the pandemic, right? I mean, data quality concerns aside, even like, for instance, in the city of Austin, like, again, city was blind without having access to especially the major hospitals' data about the incidents. And as you mentioned, Barbara, basically they didn't want to share the data in case the other hospitals may have access to that and may get a competitive advantage. And I guess at the end of the day, they were able to find a middle ground to come up with that basically public health dashboard and data repository. But even at that time of crisis, there were many concerns. And I guess that's also what makes our life in US a little bit more difficult compared to Europe, where you would have a national governing body of data. And it will be interesting to see. I'm also looking forward to see one day, because at the end of the day, some of the data belongs to the patient, which they should have some control over that, or they should be in the loop in that interoperability framework. But right now we don't, or even if you try to go from one hospital to another, technically, legally, they need to give you your records, but you need to move mountains sometimes, right? So, which also have adverse impacts the way that you are treated. So it will be interesting to see. And overall, for instance, again, back to Caroline's question, Centers of Medicare and Medicaid Services overseeing Medicare, which has more than, I think, around 120 million patients, they have that aggregate data. So that's probably also one of the big basic repositories that we have. So,
yeah, and just to add to that, actually, you look at all the big tech companies, they are big into healthcare right now. I mean, Google is in, Microsoft is in, and IBM was buying a lot of healthcare data. So
totally. And Apple, right? With the iWatch.
Yes.
Everyone is becoming a health company as well. So yeah, great points. So we have 5 more minutes, but we have one last question. Nick is thanking you all, and basically he's asking a question about potential impacts of AI on healthcare data security, or potential for hacking of health records. And basically, in his experience, it's starting to become a discussion for FARPA in higher education. So, and I think Barbara touched upon this a little bit. Any other perspectives? Obviously, we have HIPAA and other regulations, but any other insights?
For some other research, I've been looking at this and pulling up data on this recently, and the more I look at it, the more I'm thinking, AI, the bad guys can turn AI into our biggest enemy, as much as we can turn it into our best friend and have it be very helpful for us. We've also got the issue that if somebody takes AI and says, how can I get into this company? What are their weak points? And they've started training AI with data from different companies that have been hacked, then this, it's really scary. right now, the biggest issue with healthcare really is ransomware. You know, the firms are their data is being locked up with ransomware. And I think AI is going to be that next big issue. So.
Yeah, no, great points, right? Especially in an area like healthcare where privacy is very important. It's at the top of, I think, everyone's list and one of the big concerns because obviously that data is power as well going forward for companies, for nations. So I think that will remain as a hot topic. But yeah, I mean, it's almost an hour. So, well, I mean, in this space, there is a lot to talk about, right? So I really want to thank you for sharing your insights, basically with our community as part of that Texas State STEM conference. And again, I believe this recording will be made available for future views as well. But overall, again, this is an exciting domain. So personally, I'm looking forward to seeing what is next and how basically data and methods like statistical methods or machine learning AI is going to transform healthcare, which basically is relevant to all of us, right? So, but thank you very much. And I want to also thank the audience for the engaging questions. And basically, it looks like we may have another comment. So Caroline is also thanking all of you. Perfect. Thank you all and enjoy the rest of your day. Yeah.
Thanks.
Thank you. Nice meeting everyone.
Good to meet you.
Yeah.
Thank you.
Likewise, very nice meeting you all. Thank you for the invitation.